Good morning, everybody. I'm Vivek Subbiah from the University of Texas MD Anderson Cancer Center. It is my pleasure and honor to present new approaches to systemic therapy of anaplastic thyroid cancer and future directions in systemic therapy for thyroid cancers. What do you need to know? In my brief agenda for today, I'll be discussing about the current and future updates for these cancers. Because of the nature of my job, I have all these disclosures. So in my brief agenda for today, I'll be discussing about why we need new drugs, new ideas. Also talking about targeted therapy that have been approved in anaplastic thyroid cancer, specifically BRAF, touching down upon selective RET inhibitors, which has already been discussed earlier, and what is the future in the drug development space, and also about multi-kinase drugs. Most importantly, talking about combination strategies, immunotherapies, neoadjuvant therapy, and future directions in this space. So why do we need new drugs, new approaches, and new ideas for treating cancers like thyroid cancers? So cancer is public enemy number one and will be public enemy number one after COVID. What can patients expect from currently FDA-approved drugs? So these are the most common FDA-approved drugs. For instance, bevacizumab or sorafenib. As a single agent, they do not confer any complete response. The survival gain is in the order of weeks to months. And these are the drugs that we have. So the response rates to these widely approved drugs varies anywhere from 2 to 20%. So today's reality is that metastatic malignancies, including cancers like advanced and metastatic thyroid cancer, remain incurable. Statistical victories with p-value less than 0.05 are hailed as major breakthroughs and advances, despite survival gains of mere weeks to months. So how did we treat advanced rare cancers like anaplastic thyroid cancer or medullary thyroid cancer before the advent of targeted therapy and immunotherapy? It was just guesswork. So what is precision medicine or personalized medicine? The management of a patient's disease or a disease predisposition and the administration of therapies that convey maximum effectiveness and safety given the patient's unique genetic profile so that the right treatment can be given to the right person at the right time. That is precision therapy. This is a departure from the current treatment practice of one treatment for the average patient in a trial and error method. So this table shows response rates when we start matching patients to therapies. The poster child for precision oncology has always been imatinib in CML and imatinib in GIST. Recently, we have so many new kinase inhibitors that have benefited the field of precision oncology that include thyroid cancers as well. For instance, the NTRK tissue agnostic approval has benefited several patients with anaplastic thyroid cancer. Crizotinib, we see some ALK fusions in anaplastic thyroid cancer. They have been benefited as well. And recently, the selective RET inhibitors, not one but two selective RET inhibitors that has been approved across all thyroid cancers as long as they harbor the RET fusion or RET alteration. Again, this is a testament to the power of precision medicine. And then we have immunotherapy. Immune system, as we all know, recognize the mutanome. We see mismatched gene defects in multiple cancers that include thyroid cancers as well. In addition, we have high tumor mutation burden. So these tissue agnostic approvals also set to benefit patients with rare cancers that include thyroid cancers. So we have a lot of kinase inhibitor therapies and the checkpoint inhibitor therapies and a lot of agents coming in the pipeline beyond PD-1 and CTLA-4 like BTLA, OX40, TIM3, LAG3. So the future of drug development is interesting because we can combine these agents for maximal benefit for human beings. Again, in anaplastic thyroid cancer, we've utilized the immunotherapies, we've utilized targeted therapies, and as you can see, because there are multiple pathways activated in anaplastic thyroid cancer, we've been able to use these agents in clinical trials and in the clinic. So these are some of the kinases, and these are some of the drugs that have been used in anaplastic thyroid cancer and are in various phases of drug development. So what is the future of clinical trials in anaplastic thyroid cancer? Starting from genomically targeted therapy. And also, we need to focus on druggables like the BRAF and undruggables like P53. Immunotherapy is going to be a part of most of the cancers in our therapeutic armamentarium. So how can we incorporate immunotherapy into the treatment? Again, we see novel antibody drug conjugates for proteomic targets. I think that is an area that is coming up in the future. So first, in talking about drug development for anaplastic thyroid cancer, we need to recognize the supervillains so that we can go after with these targeted therapies that include RET, VEGF, mTOR, RAS-RAF pathway inhibitors, and also inhibitors of P53, which are also upcoming. Immunotherapy is always in the mix. So our goal is to think about complete responses in all patients, not just tumor shrinkages. Anaplastic thyroid cancer strategy consists of first, comprehensively profile all patients with anaplastic thyroid cancer, using then thinking about multi-kinase inhibitors, neoadjuvant strategies with selective tyrosine kinase inhibitors, combination therapies with immuno-oncology and multi-kinase inhibitors, immuno-oncology combinations. Also, there are second generation BRAF and RET inhibitors in disease drug development. So we are looking forward for that as well. And of course, combination therapies of selective RET BRAF inhibitor in combination with mTOR inhibitors, RAS inhibitors, or CDK pathway inhibitors. That's also, you're going to be seeing it in the future. So first step in tackling anaplastic thyroid cancer is comprehensively profiling anaplastic thyroid cancer. So this table shows recent investigations of mutations in anaplastic thyroid cancer. So several groups have sequenced using target sequencing or whole exome sequencing and have identified many of these alterations. In fact, there was a recent paper that was published in Nature Communications just before the pandemic on the mutational landscape of anaplastic thyroid cancer and advanced differentiated thyroid cancer. Here, they demonstrate mutational landscape of 27 patients with anaplastic thyroid cancer and 86 patients with differentiated thyroid cancer by massive parallel DNA sequencing and transcriptomic analysis of 13 anaplastic thyroid cancer patients and 12 advanced differentiated thyroid cancer patients. These were profiled by RNA sequencing. Again, as you can see, the TERT, AKT1, PI3K, E1, FAX were frequently co-mutated with other driver genes, the BRAF V600 and the RAS in advanced DTCs as well as in ATCs. But you can see that the tumor suppressors, namely the TP53 and the CDKN2A, were predominantly altered in anaplastic thyroid cancer. The CDKN2A loss was significantly associated with a very poor disease-specific survival in anaplastic thyroid cancer patients or advanced differentiated thyroid cancer patients. And upregulation of the PDL1 and PDL2 were also seen in these patients. Transcriptome analysis revealed a fourth molecular subtype of thyroid cancer, ATC-like, which hardly reflects the molecular signatures in differentiated thyroid cancer. In addition, the JAK-STAT pathway signaling could also be a potential druggable in RAS-positive anaplastic thyroid cancer findings. So this mutational landscape paper provides insights into the precision medicine of future of anaplastic thyroid cancer and also advanced differentiated thyroid cancers. So what are the successes we have in anaplastic thyroid cancer? As you all know, anaplastic thyroid cancer was one of the most lethal diseases until the advent of targeted therapies. Again, earlier this decade, we found that anaplastic thyroid cancer patients harbored this BRAF V600E alteration. And recently, we used the debraphene and trametinib combination as a part of the ROAR basket study. And the response rate of 69% was seen in the preliminary data set. So this was promising. And this shows the CT scans in patients with anaplastic thyroid cancer, showing promising responses and dramatic responses in a few patients. So based on this compelling data from the road basket study, the FDA approved debraphene and clementine, the BRAF and MEK inhibitor combination for patients with BRAF V600E anaplastic thyroid cancer. So this is the first FDA approved treatment for this aggressive form and lethal disease of cancer. Again, this approval was less than a sample size of 30 patients in a single arm study. Again, this shows the power of precision medicine, that even with a handful of patients, a few patients, especially in rare diseases, as long as the response rate is high and they benefit, the FDA is open for an approval. So, as Dr. Laurie Worth mentioned in the previous lecture, we have the selective RET inhibitors for thyroid cancer, selpercatinib and pralsetinib. So these are superheroes that have arrived for RET aberrant thyroid cancers that include the RET mutant medullary thyroid cancer and RET altered all thyroid cancers that include anaplastic thyroid cancer, papillary thyroid cancer, and all RET fusion positive thyroid cancers. So the discovery, preclinical, and rapid clinical validation with registrational intent of selective inhibitors in the RET space are a testament to the power of precision medicine. So all RET aberrant patients should be identified. All medullary thyroid cancer patients should be sequenced so that we will know that these patients will benefit from one of these selective RET inhibitors. All thyroid cancer patients will need to be sequenced, not just for RET fusions, but also for NTRK fusions, for high TMB, for NTRK fusions, and ALK fusions, so that these patients can benefit from these targeted therapies. So let's go to a case. This is a 49-year-old man with a history of advanced medullary thyroid cancer, status post thyroidectomy, and the patient harbored the RET M918T mutation. This patient presented to the clinical trials clinic after progression after 6 multi-kinase therapies over 7 years. The patient received sorafenib, vandatinib, cabozantinib, 2 investigational agents, and another investigational combination, vandatinib plus everolimus. Unfortunately, this patient progressed on all these 6 multi-kinase inhibitors. Each treatment was discontinued for disease progression in the liver, most recently with hepatomegaly, large volume ascites, severe fatigue, and markedly decreased performance status. When the patient presented to our clinic, the patient was cachectic, had 30 bowel movements with a rapidly declining performance status. So molecular analysis of the circulating cell-free DNA isolated from blood taken before the investigational combination of vandatinib plus everolimus, although vandatinib everolimus are FDA approved for other malignancies, including vandatinib for thyroid cancer and everolimus for renal cancer and breast cancer, the combination was still investigational. So the blood isolated before enrollment on this clinical trial not only identified the RET M918T mutation, but also identified the gatekeeper, the V804M mutation. Again, what we do next in this combination, unfortunately, none of these agents had activity against the gatekeeper alteration. So we knew in the preclinical models that selpercatinib was one of the agents that was highly potent and selective RET inhibitor that had preclinical activity against gatekeeper mutants, in addition to the de novo mutations. So this patient with sporadic M918T with an acquired gatekeeper alteration was treated with selpercatinib in an intra-patient dose escalation protocol. The patient benefited from this treatment. There was rapid dissolution of diarrhea and pain within the first week. The calcitonin and CA that was like 360,000 and 5,700 respectively normalized within a month of starting treatment. There was reduction in the tumor size by minus 54%. All side effects were grade 1 and have not interrupted dosing of selpercatinib. So as you can see, the patient sequentially progressed from multi-kinase inhibitors and developed a gatekeeper alteration, and there was dose-dependent reduction in the tumor markers, the calcitonin and CA, with dramatic reductions in both the tumor markers with concurrent reductions in circulating cell-free DNA of M918T, V804, and V804L. So this shows the power of liquid biopsy, the power of precision medicine, and the need for sequencing therapies and sequencing these patients with next-gen sequencing technologies, and shows the power of precision medicine. So we need to keep sequencing these patients as and when they respond or progress to treatment so that we can understand more about these patients. So here shows the dramatic reduction in the hepatomegaly, and we could see the dramatic reductions in the ascites as well in this patient. So this undoubtedly benefited this patient who had medullary thyroid cancer, sporadic, with an acquired gatekeeper alteration. So again, this was one of the first patients to be treated with a selective RET inhibitor. And I can share how I felt after treating this patient. Then I felt like some watcher of the skies when a new planet swims into his ken, like Stout Cortes, when with eagle eyes, he stared at the Pacific Annales men, looked at each other with wildsome eyes, silent upon a peak in Daniel. So I felt like John Keats on first looking into Chapman's Homer. So you see the RET inhibitor timeline. RET was identified as an oncogene in 1985. It was one of the first oncogene kinase fusions cloned from an epithelial tumor and has since been found to be oncogenic not only in papillary thyroid cancer and medullary thyroid cancer, but multiple other cancers. In 2012, RET fusions were identified as drivers in non-small cell lung cancer. In 2017, we saw the first in human clinical trials, and in 2020, we had the approval of not just one, but 2 selective RET inhibitor drugs. So you can see the FDA approval timeline of 3 years from the first in human therapies, right? So this shows the power of precision medicine in 2021. The future I envision is going to be combination therapies and second generation selective RET inhibitors in this space. So what's next? That same patient who had a dramatic response to selpercatinib was followed clinically, had a very reasonable performance status and quality of life for almost over 2 years on selpercatinib. And at some point, we continued to treat the patient, and at some point, the patient's tumor markers started increasing. So we saw development of this solvent front alteration called the RET G10S, RET G10C, and G10 RET R. And these are supposed to be the resistant mutations to selective RET inhibitors. So we identified the structural basis of acquired resistance to selpercatinib and pralsetinib. And this is mediated by non-gatekeeper mutations in the solvent front and hinge domains. And this recapitulates Charles Darwin's evolution. And they were cross-resistant to pralsetinib as well. And as you can see, there was a dramatic reduction in the circulating cell-free DNA of all these RET mutants. And slowly, at the time of progression, the solvent front alterations and all the alterations started popping up. So this shows the structural basis of acquired resistance to selpercatinib and pralsetinib is mediated by non-gatekeeper RET mutations. The identified selpercatinib RET mutants are cross-resistant. This shows the crystal structure of the RET selpercatinib and RET pralsetinib complexes. Selpercatinib and pralsetinib use an unprecedented binding mode to dock into the RET kinase. So in order to overcome the solvent front resistance alterations, we need effective second generation RET inhibitors that cover the gatekeeper alterations and new solvent front mutations. There are 3 of them at least in drug development, and a couple of them have already entered the phase 1 clinical trials. So we keep our fingers crossed and hope that these drugs will benefit patients who progress on the selective first generation selective RET inhibitors. this was another patient with, of course, KIF5B positive non-small cell lung cancer. This may be relevant to RET fusion positive thyroid cancers with an off-target resistance mechanism. The previous one I showed was an on-target resistance mechanism. This one was an off-target resistance mechanism. In this case, there was an NTRK3 fusion as an acquired resistance mechanism to selpercatinib in RET fusion positive non-small cell lung cancer. And this is an interesting mutation. So two fusions, one driver fusion and one secondary fusion that is an acquired resistance mechanism to selpercatinib. Unfortunately, by the time we received the analysis, the patient did not make it through. But we went back to the lab and we made a cell line in collaboration with our preclinical collaborators with a cell showing both RET fusions and NTRK fusions and treating them with selpercatinib and larotrectinib and both, and showing that the combination can overcome this acquired NTRK resistance in RET fusion positive preclinical tumor models, so that in the future, if there is any patient who develops this NTRK3 fusion as an acquired resistance, has some preclinical data to go with, so that we can combine that in the clinic. So what's next for medullary thyroid cancer? A comprehensive genomic analysis of medullary thyroid cancer showed, of course, RET as the common driver alteration. Beyond RET, in RET wild type patients harbored 2 out of 4 patients with RET wild type harbored mutations in the KRAS and HRAS pathway each. And most frequent genomic alterations were amplifications in the CCND1, the FGFR3, the FGFR19, and alterations in the CDKN2A. Again, there are druggable and undruggable co-alterations. Again, undruggable in the sense, undruggable so far, but hopefully we will have a drug to go after these undruggable alterations too. So what are the undruggable alterations? Of course, we have the big 4, the supervillains, KRAS, MYC, beta-catenin, and P53. With inhibition and actionability of KRAS G12C, now the KRAS field has opened up. There are drugs in the developmental space for P53 going after beta-catenin and MYC. So the future of drug development in this area is very exciting. So we need superheroes, which are drugs, to go after all these targets. And we need to identify all these supervillains which are driving these cancers. And the future of drug development is combining the superheroes, right, and targeting the supervillains, and providing the immunotherapy as to help these superheroes overcome the supervillains. Thinking about CDK inhibitors, the PI3K, the mutant selective PI3K inhibitors are coming. I think so far we had unselective PI3K inhibitors, which have been challenging in terms of dosing. And the mutant selective PI3K inhibitors are going to be interesting and coming into phase 1 studies soon. We have the RAS inhibitors, multiple RAS inhibitors, not just for KRAS G12C, but KRAS G12D, and we are all in preclinical space, and we hope to see them in clinical trials. And CDK inhibitors. CDKN2A seems like a common theme in multiple thyroid cancers, and the jury is out still there to see if this can be combined with either BRAF or RET inhibitors to see if we can overcome the primary or acquired resistance to these monotherapy agents. So taking a step back, emergence of resistance mutations severely impacts the durability of tyrosine kinase inhibitors in cancer. So the model of emergence of TKI resistant mutant clones is this. So the overcoming resistance mutations in oncogenic drivers is essential for effective precision therapy. First, we need to identify the mechanism of resistance to first generation selective RET. So we have identified at least 2, the solvent front mutations, the hint mutations on target, and NTRK3, and among others off target. So how do we tackle them? Either combination therapies or therapies earlier in the disease course, and developing second generation RET inhibitors to overcome these solvent front alterations. I think that would be the wave of the future. Also, an important theme across oncology is converting cold tumors to hot tumors. As we know, RET mutant MTC and many other thyroid cancers are cold tumors. And how do we convert these cold tumors, which are not sensitive to immunotherapy, to hot tumors? I think that's going to be a very hot topic in the future. There are several ideas that are being tested in the clinic, like inhibition of the VEGF pathway and giving novel intratumoral immuno-oncology agents to see if we can convert these cold tumors to hot tumors. Another option is the neoadjuvant approach. So surgery, as we all know, is the best targeted therapy. It's the best option for curative intent. We know 38% of node negative patients have residual disease. 90% of node positive patients have residual disease, and 10 to 15% of patients present with distant metastasis. The current treatment options, even with the best selective targeted agents, are non-curative. Neoadjuvant therapy with RET inhibitor therapy has potential to improve disease-free rates. So I'm thinking future drug development, once these drugs are approved, should take them earlier in the disease course, as we have seen with lung cancer. So all I spoke about is genomics, and genomics. But it's not genomics. It's beyond genomics. As we know, the story of the 6 blind men and women, 6 blind scientists and elephants story. We need a molecular fingerprint and portrait of every patient walking in the door beyond genomics, transcriptomics, metabolomics, microbiomics, mutanomics, lipidomics. So that may predict responses not only to targeted therapies, it can predict responses to immunotherapy, chemotherapy, and antibody drug conjugates. Each modality gives us a piece of the puzzle akin to the parable of the 6 blind scientists who touted and touched a different part of the elephant, such as the tusk versus the trunk, and therefore have vastly different views of the elephant. Panomic testing is going to be a requisite for comprehensive analysis and may require complex computer algorithms for data integration and computation, but it's coming to a clinic near you. Also, the current paradigm is we treat in a one-size-fits-all approach. The future paradigm is going to be customized therapies. Metastatic cancers at the molecular level are like human fingerprints, right? Human fingerprints are different, or like malignant snowflakes. Malignant snowflakes are different. Snowflakes are different at the molecular level. So metastatic cancer are snowflakes at the molecular level. So each patient will need a customized therapy to target almost all the alterations in therapy. I think that's going to be, in the next decade or so, the change in drug development paradigm from one size, one drug, one match, to a customized therapy for every patient. Now the whole world is engulfed in the COVID. And again, we thought we balanced the cancer care for COVID. Unfortunately, Delta has put a wrench in our efforts. But hopefully, in the near future, we can overcome COVID and continue to focus on oncology drug development. So, talking about oncology drug development, one of the silver linings of the COVID-19 pandemic and the cancer clinical trial pandemonium is finding the silver lining. So most of the clinical trials in drug development for immunotherapies and targeted therapies were designed using clinical trial centric methods, right? The protocol, the clinical trial protocol, was designed based on the protocol. So the pandemic has given us thought and given us common sense and common judgment to develop protocols using patient-centric methods, include telemedicine, etc. So hopefully we can learn from these lessons and apply for next generation clinical trials, from moving on from clinical trial centric to patient centric. So the strategy for drug development in thyroid cancer is, first, we need to identify mechanisms of resistance to first generation selective RET inhibitors. We need to overcome resistance mechanisms to first generation selective RET inhibitors. We need to develop second generation RET inhibitors. Think about neoadjuvant strategy, also combination ideas, and also think about combination of agents with non-overlapping toxicities. And one more thing is that we need a national and international registry of genomics and beyond for these rare cancers. So what is the future of drug development in thyroid cancer? Again, the revolution of panomics is here and here to stay, and is growing. Research biopsies, as we saw, and their yield is the key. liquid biopsy is going to be coming up more and more and incorporated into disease management. And also there are going to be more drugs being developed defined by molecular histology, independent of histology, and thyroid cancer would definitely benefit from such drug approvals. Importantly, patients will derive clinical research. As you know, thyroid cancer is a small group and rare cancer. I think social media and self-driven molecular testing is going to revolutionize patient care, and our systems need to adapt and adopt to this form of research post-pandemic. I'm available in Twitter. This is my Twitter handle, and this is my contact information. I thank all the patients and their caregivers for participation in this study. We thank all the study investigators and the support staff and all the participating centers and the Independent Data Safety Monitoring Committee, and thankful for all the research support that I get from MD Anderson and also NIH. Thank you so much. The time is now. Together, we will end cancer. Thank you for the opportunity.